chest tubes?
Not very.
Not very well. By the end, you will. It's going to be awesome. So, if you're asked to help set one of these up, they come in a big, giant package. It looks like a sterile package. This part on the back is sterile. This is not. So it's not actually a sterile package. You don't have to open it with sterile gloves and all that. So you'll pull this out. Just don't be sticking your hand back in the sterile part. Oh. Down here at the bottom is the part that you can twist to give it something to stand on. All of chest drainage systems, regardless of brand, come with the water that you need. Some of them, the water's blue, some it's still clear. And then this brand specifically only has one port at the top, so there's only one place to pour the water. Some have a second port, and it'll say, where this one says suction, it'll say like water port or something. So this, you would just pour all of the water down in there until it's gone. It'll come down in here and it will fill this bottom chamber here. It'll turn blue so that you can see it. It needs to be full to at least this little triangle line. I would say at least once a shift you need to, if it's still on suction, you need to turn the suction off and just take a look and make sure that it has enough water, because it's bad for it to run out of water. So at least once a shift you just need to make sure. If it needs more, you just pour some sterile water down in there until it has enough. But it takes, it's not like it's gonna delete or get rid of it, every 4 hours or whatever. So about once a shift I would check it. So now we need to hook it up to suction. So how much does the wall suction need to be on?
It's usually low suction at 20 because
So this is on 20, yes. So the order will be for 20, which is this. So how much does the wall have to be on? It's a trick question because the answer is enough. It just has to be on enough suction. So the way you can tell if it's enough is this. You can see in there, there's like a little orange deal. It'll pop out here into this chamber, and as long as it has reached this arrow or beyond, you're good to go. It takes at least 80. So it can be on 300. It can be on 81. It doesn't matter. It just takes at least 80. So you just make sure that it has enough suction to it so that this can internally provide 20. Your order will say how much to put the suction to. These come preset at 20. Every brand comes preset at 20. That's how much your internal negative pressure is negative 20, so that's why you kind of start there. It is possible to move it if they, for some reason, wanted it up to 40, which is possible but not probable. You can stick your finger back in here and you can move this up or down, but you do have to make efforts. So the nice part is it can't really just get brushed up against and the suction get changed, And now you're ready to go. So when the provider is finally doing their insertion and all that, you pull out just this end. This part is not the sterile part, it's the tip of the thing. It'll have a little cap on it, and then you just stand there with it until they're ready for it, and then you hand it to them. They're gonna do the suturing, they're gonna do the securing, they're gonna do the dressing, they're gonna do all that part. So really your whole thing is to get it set up and then hand it to them when they're ready. Okay, so how often do you have to assess a patient with a chest tube or the chest tube itself? Q4. The reason why is because if you start having problems, you can end up with a tension pneumothorax, and that can kill you. So we want to be able to pick up on that something is going poorly before they end up having a cardiac arrest situation. So some things that we're going to do, we're going to do a good respiratory assessment, including the breath sounds, what's their work of breathing. They shouldn't be getting worse. They should, at bare minimum, be staying the same, if not, hopefully getting better. So if they're getting worse, we need to do some investigating and we need to intervene right now to make sure they don't move into the tension pneumothorax part. So we'll do a good respiratory assessment. We're also going to look at our chest drainage system. So again, once a shift, you're gonna look to make sure it has enough water. Then we're gonna do basically like a look through the thing. You're gonna look to make sure it's on the right amount of suction. You're gonna look to make sure that the bellows is out far enough. You're gonna look for an air leak, which we'll talk about in a second, and then we're gonna look at the output. So you're gonna find where you're at, say it's 7 o'clock in the morning, and you're gonna draw a line where the fluid, if there is any, is at, and you write 7 a.m. And then at 11, you're gonna draw a line and write where it's at and put 11. Because that way you have a good visual representation for anybody that walks in the room how it's going. It also will help you know where you were previously so that when you know what your next number is. One thing I want to point out is if you look down here, it says 1 milliliter. These are 1 milliliter increments up to 100, and then it switches to 2, up to the 200, and then over here, it switches to 10. And these are 10 milliliter increments. This is also 10, and it says it at the bottom. So when you're looking at it, just make sure you're using the right increments, each of the little hashes. Okay? Okay. Let's talk about air leak. So if you look down in there, there's like a little plastic thing and it's got holes. In each one of these columns is one hole, right? Mm-hmm. So if you have an air leak, you'll have bubbling in these columns. If you have only a little bit of air, it'll escape in column 1 or 2. If you have a lot of air, it's going to make it all the way over here. It'll be bubbling in every column or through 4 columns, or maybe only 3 is like a moderate air leak, but 4 and 5 is a large air leak. So you would want to do some investigating. So this gives you a quantifiable way to tell each other how bad the air leak that you've been seeing is. Instead of being like, there's been some bubbling, like that is not helpful because we all look at things differently and some means different to different people. So you can say, hey, I've been seeing intermittent bubbling in columns 1 and 2 throughout the day today. Or I'm seeing continuous bubbling in 1 and 2 and intermittently in 3. So, you know, and you need to let somebody know. Bubbling is bad when it comes to chest tubes. Tidling is fine. Tidling is what happens in this column with that little ball. It'll float in the water and it'll go up and down with the breathing. Tidling is fine. It's not always there. It's there pretty often. But bubbling is bad in general. So what are we going to do if we suspect an air leak? Assess. But I always start at this piece of equipment and work my way back towards the patient because I can do something about this, right? I can't necessarily do something about what's happening inside or at the patient, but I can do a lot here. Maybe it's come loose right here. This is a point that we'll talk about. Maybe it's come loose right here. Maybe you caught this tubing in the bed rail when you were putting it up earlier and you tore a little hole, or the patient's been messing with it a lot, or they were chewing on it and chewed a hole in it, or whatever they were doing. Who knows? It could be that it's come loose at where it meets the chest tube itself. So if you push this together and the bubbling doesn't go away, this is not the issue, right? If this is the issue and you push it together and the bubbling goes away, you're like, hey, we need to tighten this up right here. You know, so you can do some investigating. Maybe the air leak is at the patient, right? So you're looking for subcutaneous air. It's not abnormal to have literally directly around the tube itself, like the day of, maybe the next day, like touching the tube directly around it. subcutaneous air, because you did just cut a hole in the skin, and you can get air under your skin when you cut it, right? So, but it should be directly on the tube. If it's bigger, even a little bit outside the tube, it definitely shouldn't be up in the armpit, it shouldn't be in the shoulder, it shouldn't be in the neck. If you're seeing this, we need to be doing something because the tube is probably wrong. The tube has probably come out or something, and we have a serious issue. So, and it may be, hey, you've been having intermittent air leak in columns 1 and 2 all day. I let the provider know, they are aware. But you can pass that along to your next person and have an easy way to tell that you're still in the same spot. So we're going to assess for an air leak. Let's talk about documentation. If the patient comes to you and maybe they're from an outside facility, or you just put in the chest tube or whatever, you will have to add it as a thing. I don't know what to call it. So under lines, drains, you'll find chest tubes. You click the little square looking thing, and then you add where the tube is at. Once you do that, it'll pull up this list of stuff. You need to fill out all the way through site description. From unexpected events down is only as needed. But all the rest of these should be addressed in some way. So under activity, we're gonna pick assess. The next thing that pulls up is connectivity. We have dry suction, wet suction, water seal, and waterless one-way valve. A waterless one-way valve is a Heimlich valve, if you've ever heard of it, of those, or a pigtail. Not very often do people get admitted with those. Usually it's for a small pneumothorax that we put it in the ER and then you go home with it. Like that's the typical way with those. So you probably won't see that, but that's what a waterless one-way valve is. So what's the difference between dry suction and wet suction? Trick question.
The machine?
This thing itself. They work exactly the same for the end user. The only difference is how it internally works to deliver the suction. So they both have water in them. They both do suction. They both do water seal. It's just this one is called Oasis dry suction, and the other one's called an Ocean wet suction. So if your patient comes up with this one, and the order says wet suction, you call them and you say, hey, I need you to switch it to dry suction. Because the difference is supply chain, and me as the ER nurse, what did I pull off the shelf? I didn't even know there was a difference between the two. As an ER nurse, I just pull what's there. I pull what's there because they do the exact same job. So what you need to know is whether or not you have them on suction. And so that's the difference. How do we switch it to water seal? It's super easy. You just take the suction off. It seems like it would take more than that, but it doesn't. It's that simple. Disconnect this from suction, and then you turn it off at the wall. But make sure that you disconnect it here. That's literally all you have to do. The bellows won't be expanded anymore because it's not hooked up to suction. Now we have them on a water seal. What that means, so the way that these work in general, any chest tube, so in your house you have your kitchen sink or your bathroom sink or whatever, and the drain comes down, it makes a U, it comes back up and it goes out the wall. That's a water seal. It's the same thing because air doesn't travel through water unless you make it with the suction or whatever. So sewer air stays in the sewer and doesn't come into your house. That's why you have a U, to keep your house from smelling like a sewer all the time. That's literally the whole purpose of that. So it's the same with this. Outside air is here, inside air is here, and you can't get outside air into your chest cavity because there's nothing pulling it either way. The reason why the air can come out, because on your pneumothorax you have extra air in your chest cavity, and that has to come out, is because you hook the suction up and it pulls it out. So that's how these work. A water seal does the same thing, it just has more water in it, and it's how it personally wants to figure out how much suction comes out. So that's how our water seal works. So all we had to do was take the suction off. Okay, excellent, good for us. Let's move on. Is there an air leak? Yes or no? If there is, what did you do about it? Under interventions, tighten connections, or nothing, or whatever. Output description, so you can put in a chest tube and drain and empyema or something gross. So there might be weird colored stuff coming out. What does it look like? Describe it. We're gonna look at the dressing. Have you guys seen a chest tube inserted before? So what they do is they cut the skin, they poke some hemostat looking things in through the muscle, and then they poke their finger in there. And then they take their finger and the tube and they poke it through the hole to make sure that the tube gets in the right spot, right? But when you pull it out, the hole has to be big enough for my finger and the tube. But when I pull my finger out, there's still a little bit of stuff because I had to make it big enough. So then you put your tube in, so it's a little bit of a gap right at first. So when they very first insert it, they'll take a Vaseline gauze and put it around the base of the tube to create a seal right there at the chest wall. But after a couple of days, this can actually start to break down the skin around the chest wall, as well as the sutures and stuff that are in place. And your body has made enough new cells and tissue and stuff to create a seal on its own. So they will take this off at the first dressing change. CRT can help you with dressing changes. So they'll take this off and you'll probably just have dry gauze in the place. So you'll look and do an assessment of that, see if it needs to be changed or it's icky or whatever. And then what the site looks like. If that's it, you can stop right there. If there's something going on, like, oh, there wasn't blood in the chamber and now there's blood here, or unanticipated removal, like you tripped on this and yanked the tube out, or the patient pulled the tube out, or you walk in and it's laying on the floor. What do we do? Cover it. So if you have a patient with a chest tube, you might as well throw one or two of these in the room, keep it in your pocket, wherever you're going to remember it's at. Pull it out, cover it. Assess the patient. See how they're doing. They may be okay, but you're going to tell somebody, but you need to know how they're doing. Do we need to do something right this second? Do they have a tension pneumo all of a sudden? You know what I mean? Cover it, assess the patient, call for help, call somebody. That's what you do. Then under interventions, you put what you did. I put an occlusive dressing on it, or whatever it is that you did. Here's some examples of what charting looks like if it doesn't have an event of some kind. So up here we have dry suction. It asks how much suction are they on. Again, that's not how much the wall is, it's how much is this dial turned to. It's almost always 20. It will also say suction control chamber dry. That means the bellows. That's that orange thing. That's why you need to know what it's called. Bellows expanded to beyond the mark. The wet suction does not have a bellows in it. And then we fill it out. How much output is there? What does the dressing look like? All that. Here's an example of one that's on water seal. Of course, it doesn't ask you questions about the bellows or the suction because that's not on, but the other stuff is the same. I personally find the policy for chest tube actually helpful. In this policy, it lists things like the signs and symptoms of a pneumothorax. because maybe you don't always remember all of these because you don't take care of these patients very often. What to do if they're on continuous suction. What are you responsible for to maintain it? How often do you have to assess the thing? Maybe you don't remember where the chamber should be sitting. Like, all of that information is in here. I always pulled up the policy for blood because there's so many things that you can have with a transfusion reaction that, like, I can remember 3 of them but not all of like 7 or whatever. So I think this one's much like that because it talks about accidental dislodgement and all the things. It also has some attachments that you can pull up that include pictures of how to set up the dry suction, how to set up the wet suction. Exact same, it just has extra fluid in it. There's one that has a picture of how to tape this. So if you look at it and you're like, I know that's not taped correctly, but I don't know what it's supposed to look like. You can pull up the picture and then you can be like, oh, it's because they have it wrapped like this and it's supposed to have long pieces and stuff. So it actually has a lot of very helpful information. Let's talk about clamping. Are you okay? That's okay. I don't want you to be dying. You need to put in a chest tube.
She's been clamped.
Right? So, you're taught in nursing school never ever clamp a chest tube. It's kind of false. Much like giving a blanket to a patient with a fever. That is also false. You can give a blanket to a patient with a fever. You can clamp a chest tube. There are 2 times that we clamp chest tubes. 1, the chambers are full. This is full and we need a new one. So you go over, you get a new one. You get this one, you get them all set up. If you're still on suction, get it ready to go, whatever. There's if you can, you want to try to not disconnect right here because then you open that up to the air, right? You open up their chest to the air. So what you do is you clamp, push this down, and you pull it apart. And it's kind of like a central line cap change or something. Like, you don't want to touch in here and you don't want to touch this. So you would then grab your other one, plug it together, rehook up the suction or whatever, unclamp it, and on we go. And we continue. So that's one time that we would clamp the chest tube. You also might be asked to do a clamping trial. So there is studies coming out that show that doing a clamping trial before removal can help with needing to reinsert a tube after you've pulled it. So you go from suction to water seal. You always go from suction to water seal because you have the suction, they leave it on suction until they're pretty sure that the lung can stay up on its own. You turn it to water seal to see if it can stay up on its own. Then we might do a clamping trial, and it might be 4 or 6 hours. I would call just to make sure I'm on the same page as the person that ordered it. Like, tell me exactly what we're looking for, how do you anticipate this going, like, what are you thinking? And then you do the trial, and if they pass the trial, they almost never need a repeat tube, right? So that can be another reason why you would clamp it. Questions? It's really not that bad. Most of it is assessing what's here and assessing the patient. Because remember, the easy part is changing them to water seal. We just take the suction off. You won't do a ton of insertion, but you can now because it's actually really easy to set up too. It's really not difficult. Any questions? No? Okay.